EuSoMII and ESCR websites after the event. Unfortunately, today Dr. 𝗧𝗶𝗺𝗲 cannot join us in person, so a recorded version of her presentation will be made available in the next few days as part of the whole webinar. As you can see, there is a QR code, so if you scan it, is gonna be useful for the CME credits. So as you know, this webinar series is dedicated to exploring how artificial intelligence is being applied across different subspecialties. And each session is jointly organized by EuSoMII together with another relevant European subspecialty society. Today's session represents the sixth webinar of the series and is jointly organized with the European Society of Cardiovascular Imaging. During this session, which is going to be focused on artificial intelligence in cardiovascular radiology, we are going to discuss how AI is going to improve diagnostic accuracy in cardiovascular imaging, how this can support clinical decision-making and address real-world implementation challenges in the daily practice. But instead of having two sessions of 20 minutes, we're going to have one session of 20 minutes now live, and then the other one of Dr. 𝗧𝗶𝗺𝗲, followed by live Q&A session with discussion. You are welcome to submit your questions during the session of Professor Vliegenthart, and we are gonna submit the question to Professor Vliegenthart later at the end of her presentation. But with further ado, I leave the floor to Professor Salgado. And I thank you all for participating to our webinar today.
Thank you, Emanuele, for this introduction. It is my pleasure here to introduce my friend and colleague, Professor Vliegenthart from the University Hospital in Groningen. Rozemarijn doesn't need any introduction, I guess, but she has been past president of ESCR, and she is also the current Congress president of ESCR. We're going to have a really wonderful meeting in October of this year in Rotterdam. And on this occasion, I would like all to invite you to go there and enjoy the nice atmosphere and also to learn about cardiovascular radiology and AI in cardiovascular radiology. So I think it's time to move on. So Rozemarijn, I think that you can start your lecture.
Thank you very much for the introduction. Can you hear me well?
Yes, all fine.
Great. I will share my screen now. Let's see, can I share my screen? Do you see my screen now, just to be sure?
Yes.
Yes. Yes.
Wonderful, thank you. So I'm going to be talking in the next, say, 20 minutes about the current role of AI in cardiovascular radiology. So basically, where are we now? These are my disclosures. So there's great interest in the field of cardiovascular imaging in the impact that AI can have now and in the coming years to really optimize the entire pathway from the first planning and protocoling of exams all the way up to management of the patients and follow-up. You see that here depicted. This is from a statement from the SCCT from 2 years ago on cardiac CT. And at this moment, the expectation is that AI can result in cardiac imaging in better images, a reduced workload, not only for the planners, but also for technicians and especially radiologists, higher accuracy of the evaluation of cardiac images and the measurements, a lower variability in evaluation, and finally also in a better prediction of outcomes and disease progression. And most evidence so far, and also most of what we have as applications at this moment are on image reconstruction, image analysis, including quantification, and incorporating that in the report. So we will be mostly discussing that in the next slides. But first, one step back. When you look in literature, you see that in the past 10, 15 years, there's a huge increase in the number of papers in AI in cardiac imaging. But that's good news. There's a lot of activity, and you see all kinds of really interesting potential applications, like looking at chronic total occlusions, looking at thrombus in the left atrial appendage, we look at fat around the heart, etc., etc. It is important to realize that most of these are currently not available or used in clinical practice. There's a huge gap between all these interesting developments and what finally becomes available as commercially AI software. For an up-to-date overview of the commercially available software products, I kindly refer you to the radiology.healthairegister.com website, which gives you an up-to-date overview of all the different products, not only for cardiac imaging, but for all of radiology. And I checked last week, we have 16 cardiac CT products on the market and 7 cardiac MRI products. So much less than you would expect based on all the research activity. We kind of see this huge gap between these developments and what we use in real practice. And that was basically the motivation for developing the AI statement of cardiac CT and MRI that we worked on 2 years ago, because we know that AI can be a huge positive effect for increasing efficiency, but the utility at this moment, unfortunately, falls behind. There are claims of improved accuracy and speed, but limited evidence for many products. And even if there is FDA clearance, CE marking, it doesn't mean that it's used a lot in clinical practice. And you'll see that probably in your own institution as well. Also, when you want to adopt AI for your daily workflow, it's probably very costly to implement it and to use it. And at this moment, we are faced with a lack of a framework to evaluate the maturity level of the AI solutions that we could hopefully implement in the future. And for this reason, all cardiac imaging societies, as well as EuSoMII and RSNA, we got together and really thought about how can we evaluate the applicability of AI for cardiac CT and MR at this moment. So we wanted to create a reference point for responsible AI adoption. And we did that, and I will show you how we did that with what method. And we published that in Radiology last year. And based on the number of downloads and all the other scores, we see that this really provided an important work for many of our colleagues. One specific thing that we did was try to come up with a framework to evaluate how far in the development an AI solution is for a specific part of the cardiac imaging workflow. And for this, we use the TRL scale. TRL stands for Technology Readiness Level. And this is something that's already been used for years in NASA and also in industry. But we kind of adjusted that to be applying that to AI solutions. And it helps by using a common language per development stage and helps to really assess how far an AI is towards clinical application. So this is the entire scale. TRL1 is the lowest scale, and it goes all the way up to 9, where it is basically widely adopted in clinical practice. Very shortly, TRL1 and 2 are really just primary research, and it's just the first steps in the development of a prototype. Proof of concept, very small data set, so really the starting points for the next steps, which are validation, TRL3 to TRL6, increasing steps towards using this and validating this in clinical practice, including larger testing sets, multi-center, multi-vendor evaluations, and focus on optimizing the metrics of the AI solution. And finally, we get to the actual deployment phase, where the prototype is demonstrable, effective in clinical practice. There's work towards regulatory clearance, workflow integration, and actual demonstrated benefit. And of course, this is where we want to aim to get with our AI solution so that we can really use it in clinical practice. So what we did is went through the entire workflow from the first test selection all the way to prognostication and mapped them on this TRL scale. So let's go through that for cardiac CT and MRI. First of all, test selection. There's a lot of interest to using large language models to analyze the medical dossier of the patient and check whether there are contraindications for a specific test so that we can optimize the selection of the cardiac imaging test for the specific patients. And this can also help to reduce low-value, high-cost imaging. In the end, we can use predictive AI also to optimize scheduling and scanner use. At this moment, there are some papers for general radiology, but as far as I could find, there are none specifically for cardiac imaging at this moment. So this is really still in research phase for cardiac imaging. A lot of work has been done on image acquisition and reconstruction. And actually, a lot of these developments are probably already implemented in your own scanner, and you may or may not be aware that, for example, the images that you're looking at are created with the help of deep learning-based reconstruction techniques. In CT, and you see here 3 different examples from different vendors, it is very useful to use deep learning to reduce the image noise. And you see that here for for coronary CT on the left image and the middle image, and for cardiac CT in general on the right image. Now, there's 2 ways that you can use this. You can optimize the images that you have, either at the time of acquisition or afterwards, or you can use this optimized image reconstruction to reduce dose to start with, meaning you can go to ultra low dose imaging for your cardiac CT. There's one caveat though. There are reports that show that there is the possibility of hallucinations and reverse hallucinations when you use this kind of AI. You see an example of that on the right, where it's difficult to assess whether an abnormality was actually present on the more filtered back projection or iterative reconstruction images, or that there may be an induced abnormality on the AI in the reconstructed images, which were not there on the original images. So it's always important to always go back to the less, more noisy images that were basis for the AI reconstructions. Another way in which AI is used in reconstruction of cardiac CT images is by correcting for motion. You see here on the left side a coronary CT with motion in the RCA, and this makes the entire test then inconclusive. And we really aim to be excluding coronary artery disease with this examination, and this could lead to further imaging. When you use this kind of AI reconstruction, it can reduce, based on all the images that it has available of this particular patient, it can come to an AI-based motion correction, as you see here, which makes this scan then evaluable with good correlation to invasive coronary angiography. And this may prevent unnecessary coronary angiographies. For MRI, we see developments towards support for automated planning of the correct planes to perform. You see here, this image shows you completely AI-based sequence of cardiac imaging acquisitions, from localizers to cine images in the different planes, to T1, T2 mapping, and the late gadolinium enhancement images. And for regular exams and for less experienced technicians, this can help to have more robust, standardized planes of your acquisition. It can also reduce the planning errors when you compare it to AI, to less experienced technicians, and it can reduce the idle time between acquisitions. So it can also improve your efficiency of use of the scanner. Now, another really exciting development in MRI is accelerated case-based data processing. This means basically that you need to have less time to fill your case space to get your images. You can use that in two ways. On the one hand, you can use the same time but get a much higher spatial resolution, as you see here on the left side. Or you can really undersample your case space filling and still, due to the AI, get to diagnostic evaluable images. You see that here on the right. The A shows you the original scan series. B is a 9 times retrospectively undersampled image, which is then reconstructed back to a diagnostic image in C just by using deep learning. And this way you can really shorten the time of a cardiac MRI protocol. And if you are doing cardiac MRI, you know that the cardiac MRI is usually quite a long scan, up to 40-45 minutes. So if we could reduce that, for example, by half, this would really have a huge impact in clinical practice. So for the image acquisition and reconstruction that we took together in our statement, you see that there's a broad a range of technology readiness levels. Some are more still in the development phase, and others are already deployed and could already be the basis of the images that you see in clinical practice. Now let's move on to image analysis and interpretation. Again, a lot of work has been done in this field, and most of the applications at this moment are exactly in this area of the cardiac imaging workflow. First of all, CT. Coronary artery calcium scoring is a commonly used parameter which can now be derived automatically by AI-based software. And this can be done by multiple different vendors. Two are visible in this image, and you can even apply that on chest CTs. This is just something that is an easy tool and saves us time. Next step is when you evaluate the coronary CT, we look at the presence of plaque and specifically stenosis and the stenosis degree. And we use also categorization of these stenoses according to Quadrat. There are now softwares on the market that allow the automated analysis of the presence of stenosis. You see here depictions of the output of two different softwares. So they give different reflection of the location and the severity of a stenosis. For example, an application could be that in nighttime, when there's less expertise around, usually this can already provide the first evaluation. Another hot topic in coronary CT at this moment is the quantification of coronary plaque. This is something that basically is not something we can do by hand because it's just too time consuming. And so we need automated methods to help us with that. And I show you here one landmark study that developed an AI solution in this field, looking at plaque volume and diameter stenosis. You see here the segmentation of the different types of plaque in the color images. They used different training cohorts. They had 3 separate testing cohorts. They compared to expert evaluation, invasive coronary imaging, and prognosis. And they found that their AI solution can really help clinicians by being very rapid, but also robust and accurate. Now, that sounds all very good. And there's a lot of interest to use these kind of quantifications, for example, to look at the impact of new medication on the amount of plaque. However, a recent statement by the SCCT compared 7 different FDA-cleared vendor software solutions all looking at the amount of coronary plaque and the types. You see here a comparison on the left of all these different software products. They have widely varying amounts of plaque and types of plaque. And you see that also depicted in the color coding. So at this moment, we don't really have a standardized way of quantifying plaque. And with all the diversity in softwares, we can also not compare one to another. So we will need more work in this with an outside reference standard that will help us to really get to a robust quantification of plaque for use in clinical practice. Now, one very important tool nowadays in cardiac CT is CT fractional flow reserve. It's basically a modeling of the effect of a stenosis on the downstream flow. And if the flow is reduced, then we call it hemodynamically significant. You can also do it with invasive imaging, with invasive coronary angiography, but it's a very costly procedure and it adds time there on the CAF table. But we can now also get an estimate, as said, with CT. The original software is based on computational fluid dynamics, but we now also have newer AI solutions that use deep learning for the same purpose. And I show you here one example of a AI solution that can just do this on site with just one click, which is a major advantage compared to older solutions that either took very long or needed sending the CT offsite. Now in MRI, I think one of the major pros of AI is the automated segmentation of the cardiac chambers. And you see that here in short axis images in the middle of the slide. The segmentation of the contour of the left and right ventricle. You see the endocardial contour of the left ventricle and the epicardial contour. So you can quantify based on this in systole and in diastole what the function is of the heart and what the mass is of the left ventricle. It used to be something that we needed to do manually, but now the commercially available softwares allow to do this automated. And you may not know, but many of these softwares now use AI for that. So many centers that do cardiac imaging are already using AI-based software. Now, there are some caveats, especially for the right ventricle, especially the basal slice, as you see here on the left side. You need to still check that the segmentations are accurate so that also the parameters that you get are accurate. But overall, this is very helpful in clinical practice. And next step is what's called strain imaging. You see an image on the right side that gives a simple idea of this evaluation. Here, the function of individual segments of the myocardium are depicted, and it can already show subtle signs of dysfunction. Now here, there's more still in development, and there's also quite variable results across vendors at this moment. In MRI, we also have new quantifications, actual parameters that we did not use before. And one particular one is looking at scar or infarction with late gadolinium enhancement. Normally, we would do a visual analysis of the severity of the late gadolinium enhancement, but with AI, we can quantify the actual area and extent of the myocardium. And this helps to improve the prediction of prognosis. The newest development in these fields, and these are papers just from very recent in Nature, is using the newest types of deep learning called video-based transformer techniques to directly go from an imaging exam, in this case cardiac MRI, to a specific diagnostic classification. And these are images from two different papers in this field that use the entire cardiac imaging exam, so all the cine images and all the other images available. In the first study also used the late gadolinium enhancement images. And from this model, they predict what is the diagnosis, what type of cardiomyopathy is present. So I think this is a really interesting development. It doesn't give the whole answer, of course, because we don't only look at, is this a dilated cardiomyopathy or is it a hypertrophic cardiomyopathy? But there are many other parameters that we evaluate, for example, the severity of late gadolinium enhancement, etc. So it's not just a yes-no diagnostic classification that we do, but I think it's a really interesting approach that will need further development. Also, when you look at the AUCs on the right, which are still quite variable. So here again, we see a broad range of technology readiness level for the analysis of both cardiac CT and MRI, but also quite a number that we already use in clinical practice. We also looked at in detection of incidental findings. So on a cardiac CT, we can also evaluate other things that are not related to the primary indication of the scan, for example, pulmonary nodules, liver steatosis. And we do know that there's also software based on AI that can automate the evaluation of that. And I think this is a hot topic, the evaluation of coronary calcium on chest CT scans. So chest CT scans are not gated, but you can often still say something about the severity of coronary calcium. And there are now there's now a statement in the US on this that really promotes looking at coronary calcium in chest CT. Again, you can use AI software to do that automatically. And there's even a proposal how you could do this in clinical practice, even based on retrospective scans, where you automate the quantification of coronary calcium and then also have an automated report generated in your patient health record to be sent out to the patient and the referring physician. So here we do see already that there's deployment of these kind of AI solutions in clinical practice. And actually, that's the only way really you can involve this in clinical practice, in my opinion. Now we're getting to the end, near the end of this presentation. Prognostication is really important in cardiology. We know quite many traditional clinical risk scores, and with newer AI techniques, we can integrate the information from these kind of clinical risk scores with imaging biomarkers and clinical data, and that helps to improve the prediction of, for example, the outcome of a patient and progression of disease. You see here results from one study in this field. We do need more validation of these kind of approaches for incorporation in clinical practice. So here we're still in research and early development phase. And lastly, there's a lot of interest in LLMs, not only to improve the reporting of our findings and explaining them to patients, but also you can use this for automated interpretation and classification of what we write in the report. You see here an example from both CT and MRI, where on the basis of a CT report, automatically the 𝗧𝗶𝗵𝗶 classification was depicted. And on the other hand, based on the cardiac MRI report, different LLMs were used to determine what kind of cardiomyopathy was available. However, I think that when we evaluate a scan and we do we write down all the different components of the report, we should also be able to classify that in the end, of course. But it can be a helpful tool for younger colleagues who are still learning those kind of classifications. So when we look at the entire cardiac imaging workflow, this is what we came up with in our AI statement published early last year. And our aim is to update this every couple of years because, as you know, the developments in AI are going very fast. And we hope that more of these applications will move into the direction of deployment. I thank you for your attention and I warmly welcome you to Rotterdam in October for the annual ESCR conference. Thank you.
Thank you, Rozemarijn, for this another excellent lecture. I've seen some questions going into the chat, but please keep the conversation going. If you have any thoughts or comments, please place them in the chat and we will deal with them at the end. So, Emanuele, we have another speaker, but virtually.
Yes. I want to thank you, Professor Vliegenthart, for the very nice presentation. Very interesting. And yeah, maybe we can start already with a question. Or I found so we have a question from one of the attendees, and it's what are your thoughts about potential hallucinations of deep learning-based reconstruction methods?
There are some incidental reports on this that because of the smoothing of deep learning-based reconstruction, and I'm talking about CT, it may be that small abnormalities may no longer be visible. So this is a reverse hallucination, basically smoothing away a more subtle finding that could still be clinically relevant. On the other hand, there are some suggestions that you can induce some artifacts with this deep learning-based reconstructions that make you think that there may be an abnormality. So what I always mention is that it is important for us to not only look at those really nice-looking deep learning-based images, but that we also should look at the more regular, for example, iterative reconstruction-based images, to be sure that if you have something more subtle, that it's actually a finding or not. So I would say it has pros and cons, but we are, of course, always the ones that finally need to decide on whether what the final diagnosis is and what the final findings are. So it's just something to keep in the back of your head.
I think also a good question for everyone that is present. And that is, I think, a lot of the benefits that AI stems from which data set that you are going to use, the quality of the original data set that you are going to use to train your model, and also of the objectives that you set to train to. And I was wondering, at this moment, the data models that we are using, are they universally applicable to every population in every part of the world? Because I can imagine if you train a model, for example, with Western people, and then you go to South Asia, that maybe the results will not be what you expect because you're applying a training model to a different population. So I think that for the future, the accuracy and the quality of the data is as important as the technology itself. I don't know what my thoughts are about that.
I completely agree. There's many types of bias that can occur in the development of an AI solution. And one of them is, well, maybe more than one, is related to the population and the range of disease in that population that you use to develop the AI. One of the solutions or one of the recommendations that have been given is that with an AI solution, there's also a whole information sheet describing what kind of population, what kind of specific characteristics were in that population that was used to develop the AI. For example, if you only used congenital heart disease patients, you cannot assume that that is also transferable to elderly with a possible myocarditis, right? Just to give a very extreme example. But it is important to know what kind of training data were used. And many times at this moment, that's unclear.
I have a question for Professor Vliegenthart. It was I read the article and the presentation was very interesting. What do you think about what should be the approach for the radiologist when he wants to implement AI software in cardiovascular imaging. So you mentioned the TRL scale. That's, as far as I know, is also used, for example, for EU Horizon for different softwares when someone participates to the grants. But for example, the European Union use like more risk-based approach for the legislation, for example, for the AI Act of 2024. So what do you think would be the best approach, since you showed all the different application of the different AI software in different domains, so CT, MRI, different steps of the diagnostic process? What would you think would be the best approach if I want to implement a software in my in my workflow?
That is a broad and complex question. There is even a guidance document by ECR published a couple of years ago that gives, I think, 10 points to questions that you can go through before you start thinking about buying a specific software. So apart from the AI Act, which has a number of ramifications for us as radiologists and for implementing AI, when you just focus on whether or not you would be interested at all in a specific application, I think you have to look at your own clinical workflow and see where you think that there could be the most advantage in terms of, for example, increasing efficiency, to be looking at a specific AI software. For example, if you're doing a lot of TAVI scans, like these are before aortic valve replacement, you could be thinking about a product that automatically measures AI or aorta diameters. If you are using a lot of if you make a lot of cardiac MRI scans, you may be thinking about software that automatically measures the cardiac function. So it depends on your clinical practice and the diversity and the type of patients that you scan. I would say that is one. And then I think it's fair to do a comparison of what's on the market, which you would have most benefit from in your workflow, because every AI solution that you will choose, there will be some sort of impact on your workflow, and it will need to be implemented in the way that you do your entire workflow. And so there are different ways of doing that. You can have an individual software package, but you can also, for example, have a more platform AI provider that could give you access to a number of relevant AI solutions. So, and then in the end, it's about, what does it cost and what does it also yield for you? Because I think you also need to try it out in clinical practice to see that it's actually working in your own population. So, for example, in my hospital, we now have a specific AI coordinator who is looking at what would be the quickest wins for a department to increase efficiency. And he's searching specifically for providers that could help us in those areas to really improve efficiency in areas where it would benefit the most in our situation. So it's an exciting time, but it also really costs a lot of time, I think, to get the best solutions for your own hospital.
Thank you. I was wondering, and this is also a question from the audience, as we are evolving, and we as radiologists have been trained, of course, clinically, but also technologically, but until now, that was mostly how the equipment works, from CT works, or ultrasound works. But isn't it time, or should it be already time, that the basic knowledge about how an AI system works is also integrated in our curriculum, as we are one of the specialties that is experiencing this rapidly evolving technique very much in clinical practice.
I completely agree. We don't all have to know exactly how to write code for AI, right? But we do have to understand some drawbacks and from AI and specific what to look for when you do use AI products and solutions. What we did was with our residents, we set up a program. We asked them what would be the topics that they would like to learn more about. And then we involved different AI specialists. It was a short course that we provided that gave them an idea of like what is AI, in what areas of radiology can it be applicable, and some of these strengths, but also the weaknesses. Because then a resident at least has some basic knowledge to build on, because for sure they're gonna have more and more AI solutions when they become radiologists. And we published this, the overview of the program and the evaluations a couple of years ago in European Radiology.
Yeah. There is a question also from the audience regarding accountability, meaning when you use an AI system, is it still the doctor that is the ultimate responsible for whatever output is generated, or can you deflect some of that to the AI system itself?
Another hot topic. Actually, what I just learned this week is that there's currently the first legal case in the US against an AI company that actually missed something on a scan, and now not the radiologist, or maybe also the radiologist, but also the AI company is sued. I think at this moment in Europe we don't have a similar case yet, but it is something that at this moment there's no real, jurisdiction for. What is important is that at this moment all AI output needs to be supervised by the radiologist and checked. So you can't just, without even looking at if the segmentation was correct or if the evaluation was correct, just depend on the AI output. But that also means that we as radiologists still need to be the best in our imaging evaluations. And what you do see, and this is from mammography, is that there is a real chance, especially for younger colleagues, to just depend on the AI output instead of being critical of potential drawbacks and mistakes that the AI can make. But so I think it is a time to be critical. It's a time to be on the top of your game as a radiologist, because in the end, I feel we are still responsible, not only as just a worker in healthcare, but also as a medical doctor involved in the clinical care of a patient.
Because I'm young enough to, or old enough, depending on where you stand, to have seen this evolution. And when we wanted to learn about something, we had to invest our personal time in it. We had to look at research papers, we had to read it, we had to understand them. So in the end, through effort and through intellectual effort, you eventually get to understand the subject better. And I think now with AI, you kind of skip that part and you get an immediate result that you have to interpret without having this intellectual background often. And I give an example. For example, there is a lot of interest in perivascular inflammation that you can detect with the eye. And it's one of the, let's say, biomarkers, to put it that way, that has been possible to detect with new technology. But as it happens, we don't really understand what we are really seeing. Is it perivascular inflammation? What is happening? Is it like microcirculation? So I think there is also a danger where you don't understand how a specific result is formed, that you're going to give it a meaning to that is not completely accurate and deduct conclusions from that maybe are not as well informed or well formed as it used to be. So I think that therefore, when we make the transition from an AI-generated result into a clinical decision that's going to affect a specific patient, you still have to be very careful.
I completely agree with you again, Rodrigo. For AI can generate all kinds of output, all kinds of potentially interesting output, but output is not information itself. It's just potential signal. And so the criteria for using those kind of output parameters should not be different for AI versus a clinical thought through marker. You have to show in a prospective study that it has impacts and that it can actually predict an outcome, and also show what to do with the specific level of the outcome. So it's not a shortcut to just have a completely unreadable radiology report with 500 outcomes and nobody knows what to do anymore. I think there always has to be a link between what we write in the report and a specific management advice, or at least a guideline that says what to do with an output. So an AI parameter is not a shortcut to a clinical management. It still has to be robustly evaluated.
Okay, thank you. I feel that we can go on and on. I was wondering, Emanuele, if you have any questions also to address.
No, I just wanted to comment this, saying I think that's what links your reasoning to so the fact that we have something coming from AI, but we don't have a clinical reasoning behind the output is explained by the so-called black box problem, I think, because in the end, we give an input. It can be, of course, electronic medical data, but in this case, CT and MRI images. We obtain an output, like as Professor Vliegenthart showed. There are advanced models that are able to associate a whole MRI pattern to a diagnosis. But in the end, the missing link is how the software reached that's output, and I think that's also a little bit what hampers in certain cases clinical implementation also, because different generation of radiologists have to be familiar with the drawbacks of the technology and what are the potentialities, but also what are the pitfalls of the technology. And I think this is like the core of the problem, the black box.
Go ahead.
No, sorry.
And of course, AI does not know what it has not been trained on. So, for example, if you have a more rare pathology in cardiomyopathies, for example, it may be that it will never give that diagnosis because it just has never seen that. Of course, that's also the case for us, but we have probably been looking more in training books and educational materials, and seen, even if we've seen only one case ever, we could still remember that. And what you see in these examples that I showed with the vision transformer models is that the area under the curve, so the discriminatory ability of AI still is not so good. It's not perfect at all. And there's also possibility of uncertainty of the AI that we don't know, but the AI may not be as certain as the outcome that it just states. So there's now also some developments to basically quantify how certain the AI is of the prediction that it's made. And I think that's also helpful to see the specific output in the right context.
I think that this has been a very interesting discussion, and I will throw my last question into the panel here. And I would like to end with some provocative question. So there have been reports indicating when you use unsupervised models, so models that just look at the data and draw their own conclusions, that these models often perform better or come to new insights when you remove actually what we as humans already know about the problem. So when you let the AI model take a look at the problem without human interference, sometimes it comes to unexpected but rightful conclusions regarding some problem that we as humans have never think about. So I think that people are always thinking that AI models at a given moment may become as intelligent as we are. But I'm thinking that in the end, these systems will evolve in certain ways beyond what is capable from human intelligence. And on the other hand, will remain some kind of handicap for human intuition, whatever that may be. So I would like to know from you personally, what do you think will happen in 5 to 10 years with that relation, human versus AI?
Oh, that is indeed a challenging question. First of all, I think for through unsupervised approach, you need huge amount of data, and we generally lack that for cardiac imaging. So I'm not talking about 100 scans or even 1,000 scans. I mean, these kind of data sets are just not publicly available, for one. So I think that to have that kind of model at this moment with the data size that we are looking at in cardiac MRI and CT are generally not available. But I do think that we're in a very dynamic time, and the models, for example, the foundation models, the agentic AI, it's coming on very fast. So we need to keep really on top of the developments and see how we can apply new technology, but also especially what are the pitfalls, and to stay on top of basically what we're using. And I think one of the challenging issues, and you're touching on that, is if the AI gives a prediction that I can no longer check as a radiologist, how do we deal with that? And I think that should be part of a larger discussion, because if we're still responsible for that prediction, you'd have to have a lot of trust in your AI to be able to follow that. But it may also be that you're wrong if you don't follow it. So there's no easy answer to this at this time. You see so quick developments, but also around us, not just in our imaging field, but the use of AI in all kinds of areas of life. It's just going so fast that I think this should be part of a larger discussion in radiology, how we should deal with that.
Yes, and I think that we will have this discussion for many, many years to come. Okay, Emanuele, I don't know if you have any last questions, or else I think I would like to thank the audience for listening and for actually participating. We've tried to include as many of the comments that there were into the discussion. I would like to thank you very much, of course, Professor Vliegenthart, for having her expertise in our lecture here. Emanuele, for representing EuSoMII in this joint webinar. I think it has been a huge success. Very interesting discussion. Remember, everyone, this lecture will be available on the webinar series of ESCR and also EuSoMII for later to review. And I have nothing more to do than to thank everyone who was involved, also Mercedes and Professor Akinci. And I wish you all a very nice evening and good rest of the week.
Thank you.
Bye-bye.
Thank you. Okay, I also want to thank you, Professor Vliegenthart, for the very nice presentation and the discussion, and Professor Salgado as well for the nice discussion. We conclude here this webinar. I just want to remember the appointment with our next webinar, which is going to be on AI in neuroradiology, focused on dementia imaging. And this is going to be our 7th appointment in the webinar series. And so stay tuned. And yeah, thanks you for the very nice session. And thank you for everyone to attending.
Thank you. Bye-bye.
Thank you so much. It was great discussion and presentation. Thank you.
Thank you. Thank you.